talk about understanding Tamil mental health. Are we served? So this question is not just for the Tamil community and also for all the ethnic communities of Canada. So Vasandam, is a wellness center. We were established in 1999. So we are doing the mental health in our workplace, and we are mainly concerned about mental health. We are doing addiction counseling, gambling addiction counseling, psychosocial counseling in our agency. We serve seniors mostly, but we are including all the members of the families, extended families, into the services. But our addiction and other mental health services are for everyone in the community. The services are held in Tamil, and we have groups and individual counseling. Right now we are doing home visits, etc. So we started this Zoom for the Tamil community, to educating the Tamil community due to the crisis that we faced recently. Within the last 3 months, we lost over 20 Tamil young men for drug addiction. So that is an alarming thing in our community. So that is why we started talking about it. And so people have encouraged us to continue to talk about issues affecting the Tamil communities. So this today we have organized this thinking that the majority of the community, the mainstream and other committees that are serving Tamils and other people in the mental health area, they should understand where the Tamils are coming from, why this is happening. Some of the stories you may be hearing that the Tamils are doing well economically in Canada, which is true with some people, but even among them, we are feeling that they are failing because their sons also have died, or they were victims of this drug. So that's why we thought, why this is happening, what is going on. So we have been engaged in a research, even with the suicide study. Very recently, we started a suicide study with Ryerson University. It's a pilot study. So we are continuing with other abuse, senior abuse, elder abuse, and also women abuse, senior women abuse, etc. In the past, we were involved with advisory committees with CAMH and other organizations. Even our guest today, even Nalini Pandalangat, she was in our, in Vasandam, she was serving as a member of the board. And two of the panel members, Dr. Chandrakandan, who was our first president, served Vasandam. So we are really glad to have all these guests who are here today to discuss about the issues that the Tamils are facing in Canada. As other communities also, we also face the same psychosocial risk factors what other communities are facing. But in addition to that, what are the other issues that are affecting Tamil community? The common issues that are affecting all other communities, including indigenous communities. We have seen yesterday the big rally that took place in Montreal. So there, Jane Philpott, she talked about the trauma that the indigenous people are going through, and she said we have to include racism as one of the determinants of health. So she said, we don't need more studies, we need action. We must seize this moment in history and act to prevent more senseless deaths. So we have seen even a South Asian recently was killed by the police in Peel region, Mr. Chowdhury. We have seen a black girl who jumped from the window of the 22nd floor when the police arrived there. We have seen that. We have seen even early discharge that caused death in our, young members. One of the guys who was discharged and he went and killed himself, shot himself. And that kind of thing is going on. Why this is going on? And also sometimes some of the members, when they wanted to take their children or their loved ones to the mental health services, it is sometimes impossible. They have to go 7-8 times to get form to get them admitted, and sometimes they have to even shop, hospital to hospital. One hospital says, no, he's not allowed, or he doesn't need that. So then the person tries so many times and then goes to another hospital and get admitted. Even inside the hospital, there are issues. Even the doctors, they don't understand. The Tamil community, they don't go to take these people to the hospitals. It's last resort they do. But while they are doing this, but the hospital, the system doesn't seem to understand. And they think when these guys can speak in English and talk to them nicely, and they think that they are okay and they discharge them. But it's, when they get home, it's really, really worse things happening. So we hear the Tamil community in Europe, England, even this week, there were murders, killing wife, killing the child, killing himself. So there were so many deaths even recently. Why this is happening? Dr. Daya Somasundaram, who is a member of the psychiatry unit in Sri Lanka, he has written many books, and he is now doing a research on collective trauma. What these people have gone through as a collective Tamil community, collective trauma, but they have gone through. That is why those reasons are the reasons why the Tamil people in Canada are going through mental health crisis. When you go to the hospitals in Scarborough or Markham area, you will see a number of Tamil young men are there. And the deaths, suicide deaths and the drug overdose deaths are very high among the Tamil community. So why this is happening? What are the reasons behind it? So this is why all these, the speakers are here. They are well versed. Some of them are continue to do research, and almost all of them know about Sri Lanka. All the 3 people have lived there, studied there. They have gone through the war. And Nalini, who is a researcher, she had gone to Sri Lanka. She also has done a number of research in the Tamil community, Sri Lankan Tamil community. So we welcome all the research people and all the speakers who are going to be giving you, they have wealth of knowledge. So I welcome first our speaker, Nalini Pandalangat. So Nalini is she's Dr. Nalini. She was a member of Vasandam Tamil Wellness Center. She was a board of director in the early 2000. So she's now a director of the Immigrant, Refugee and Newcomer Communities program at Sherborne Health. Is a registered social worker with the Ontario College of Social Workers and Social Service Workers. She completed her PhD at the Institute of Medical Sciences, University of Toronto, and has extensive experience leading projects and programs in the community health, hospital, and international development sectors. Nalini worked as a consultant with the New Immigrant Support Network at the Hospital for Sick Children, where she developed modules and training around culturally competent programming that would improve access to newcomer communities. Nalini is committed to developing programs that are culturally competent and relevant to addressing the needs of the communities that we serve in a participatory and responsive manner. So we welcome Nalini Pandalangat.
Thank you, Parvati. Do you want me to start with the?
Yes.
Okay, I'm really happy to be here, but also very sad that we continue to talk about, mental health and unmet needs in the Tamil community and also in very many other immigrant communities. There's been a lot of push and advocacy on the part of Tamil communities. But the reality is that the needle moves very little, right? And so it is imperative for us as service providers to continue pushing. I was just thinking when Parvati was talking about the deaths that recently happened, right? In the last 3 months, 20 young people losing their lives. When I came as an immigrant into this country 20 years ago, almost my first job was as the research coordinator of a Tamil mental health research project that was funded by CIHR. And the reason that project came about was that during that time, there was a spate of suicides that happened. This was 20 years ago. And the Tamil service providers actually reached out to CAMH to say that we really want to know what is going on with our community, and any kind of research will support our advocacy and push for program planning. And that was why I don't know if you remember 20 years ago, a man with his child fell in front of the train in the subway. And there were a series of other suicides that also happened. And that was how that research project of 1,600 Tamils came about. That was my first kind of connection with the Tamil community here in Toronto. And ever since, I've been working at some level with the Tamil community, and I really applaud the community for its resilience and for its strength. So I just want to start by saying that, which is why I've titled my presentation "Key Lessons Learned from the Tamil Community." There's a tendency sometimes for service providers to always think that we are giving to the communities. But a lot of times, we learn a lot, right, from communities. And I just want to share some lessons learned from the Tamil community in particular, and to talk about how that need has helped in informing program planning for many immigrant communities across the sector. So the Tamil community is very well entrenched in the Canadian mosaic. There have been several studies that have been undertaken. The one that I spoke about, the CIHR study, was targeted 1,600 adult Tamils in the Greater Toronto area and looked at things like depression, anxiety, help seeking. There was another study, I think, that was undertaken by Mount Sinai, and it was around different ethno-racial seniors. And it was out of that, I believe, Parvati, that Vasantham came about. And then, as we all know, the community has a very strong business and political presence, now has a significant, presence in many fields, right? Health, social services, and all of that. And I think, like Parvati said, at one level, it's a very established, very successful community. And at another level, it still continues to struggle on multiple levels, right? One of the key factors, I think, in terms of the struggle of the Tamil community and many other immigrant communities is really, that the system, the sector really don't understand communities for who they are, right? Because anytime there's a refugee community coming into Canada, we're always seen at the point where, the person comes as a refugee, right? The past is completely forgotten in terms of who were the Tamils as a home community, right? What was the richness? What was it that they brought with them that actually enriches the Canadian mosaic? And so those things are really, so you don't really think of people as people, but more in the point of entry as pre-migration, post-migration, right? Settlement. And so I think that is the basic kind of issue that and racism has a lot to do with it too, right? In terms of, having the intentionality to understand communities for who they are, right? Only then can you design programs that make sense to, the communities that we serve. So I just want to preface my presentation with this introduction, and just with thanking the community for all the richness it has given us Canadians. Can I share the screen, Parvati? Let me see.
Oh, go ahead.
Yeah, you can.
Oh, it says the host has disabled participant screen sharing.
Yeah.
Is somebody able to enable my screen sharing? Otherwise, I can just talk. That's fine.
Allowed. You could go ahead, please.
Thank you. Thanks.
No problem.
For some reason, I'm not able to do that. So I think I'll just stop. And I hope I'm not too boring or monotonous that, so I'll talk and then, so just in terms of, so my research project, after I did the CIHR, that was like almost my first or my second job here in Canada. And then it was a large scale study of 1,600 Tamil adults. And like many refugee communities, there was a very high rate of post-traumatic stress disorder, depression, and anxiety. But since it was largely a quantitative study, like a survey, I wanted to know more, really. And so that was what drove me to do my PhD here in Canada. Because I thought for any, any relevant programming, you have to have a richness of context that surveys don't give you, right? Surveys give you numbers and they are helpful to actually tell you, no, we need to kind of probe more. So that's how I went into my doctoral work. And that was really looking at adult Tamils who self-identified with depression, and really, finding out from them what it meant in terms of being healthy, what mental health meant to the Tamil community, and how they were being supported or not being supported. And I think the title of this presentation, Are We Served, is perfect because it is so simple, right? And if, a simple answer is not the way we want to be served, right? So that's also kind of, and I will kind of go through it. So, with the Sri Lankan Tamil community, if you look at where, and I know I'm preaching to the converted because most of you probably are from Sri Lanka or have been working with the Tamil community for a long time. It is a rural collectivist community, very family-centric orientation. And though I was speaking to people who had gone through war, right, and had come here and settled down, there was so much of happiness when people spoke to me about their childhoods, where they grew up, right? And there was a lot of pride in education, in home ownership, in farms, cattle, and temple, right? Farms, cattle, and temple marked everyday life. And, the cycle, the bicycle was such a common mode of communication. Travel. And then they were very gendered at that point in time because who I interviewed were all first generation immigrants. So very gendered role expectations. And the war really shook the very core of the community in terms of, there was huge family dispersion, death of loved ones, torture, loss of education, property, way of life, multiple displacements, detentions. I mean, we all know the story, right? So, but from a policy and programming perspective, why is this knowledge of the community important? It is important to know what a community has lost, right, during their migration, during the war, right? What have they lost? Because if you don't know what was valued most in the communities that have immigrated, right, you will not know how to work with them, right? How do you develop programs that integrate what is valued for a community? And it does not really take much, it can be simple things. And these are like preventive mechanisms for well-being. So, just in terms of how do you, if what was really valued was education, what was valued was, the sense of family, the collective importance, farms, cattle, like how can you have health promotion programming that tries to bring back these elements, right? Instead of trying to fit it into a frame that is Eurocentric, right? Where notions of health promotion are very different from our ethnic notions of health promotion. So that's, one kind of takeaway from the understanding of the community. When the community comes here and resettles, right, what have been the community's challenges again? One thing has been, a lot of the community has been thrown into very, very unfamiliar circumstances. Sometimes, when refugee families have started their migration journey, it might have been as a couple, but then the male spouse has been detained somewhere along the way. And then you see the wife coming here and settling down all alone and getting into that role of an instrumental provider, which probably she had not been accustomed to, right? So isolation of women, seniors, single men who immigrated here came up very strongly in my research. Women were thrown into very unfamiliar circumstances. Many of them, came here pregnant in their 6th or the 7th month and had to go through the pregnancy all alone, go through resettling, go through finding a job, everything that was unfamiliar to them, right? And then systemic barriers of language and discrimination. I mean, sometimes it doesn't matter, even if you've been in Canada for 20 years, you still face those barriers. The other very significant factor in my research study was, the marital and relationship stressors that occur because of prolonged periods of separation, right? And so when the couple reunites again, there's, gender role expectations are not met. For example, the woman has become more independent, more kind of able to function independently and take on the instrumental role. And many times when the spouse comes into the picture, they might have been earning well in very good jobs in their home country, but they are marginalized here due to racism and discrimination and so many other factors. And so there are role reversals that happen. And then there is, tension, and there is domestic violence. And our system always steps in only after the tension or the violence has started, right? We don't have understanding communities, how they come, the separations, what might happen, and we've known this for 20 years, right? But still, do we have proactive family programming? We don't. And that is what, that is what we have failed to learn. And I don't know whether it is we have failed to learn or the system does not want to learn because it needs to work differently. So what happens when domestic violence happens? The woman goes into the shelter system, right? The man is charged, right? Or is forced into a partner abuse response program, right? And what also sometimes happens is that the couples essentially sometimes don't want to be separated, right? So they start living on the sly alone, even though there is a restraining order, right? But no supports are given to them. And then all hell breaks loose one day, and there is violence, and sometimes there is, something more than violence that happens, right? And the system says, oh, this is why they should have respected the restraining order. But the reality is, you have not created a paradigm of service delivery that respects and that is proactive, that could have prevented it, all of this happening, if we had, planned our programming and family supports for immigrant and refugee communities differently, right? And this, I know, is not something new that I'm telling you, because you must have come across this many times in your practice. Again, how does the Tamil community define, conceptualize health, right? This was very, very interesting to me when I was interviewing a number of, men and women. And I was thinking, was I not framing the question correctly? Because when I talked about health, people actually talked about being able to provide for their families, being able to be gainfully employed, being able to have meaningful relationships. And then that taught me a lesson. It taught me a lesson that the community views health from a population health perspective as a resource, right? To be able to function socially in a manner that is meaningful to them and to their lives, right? And this is what, with the Western society, we have such a, very significant mind-body divide. Mental health is very distinct from physical ailments, right? And so those are the kind of, the social dimensions of health probably are not taken into consideration in the way that they should be for different communities across the board. So that was another learning. So there is an integrated, holistic concept of health. On the positive side, in terms of mental health, we found a gradual movement away from stigma, especially around mental health issues that are directly related to social dimensions, right? So, for example, depression is viewed more positively probably than schizophrenia in the Tamil community. And because there is a strong dimension of social stressors and issues that people can relate directly to depression. And it is also the work of many Tamil service providers in terms of, creating a better orientation and understanding regarding mental health that has helped that movement. For women, a lot in terms of feeling physically and mentally healthy, focused on bringing up their children, being happy in relationships. Like for men, it was the ability to provide for their families, ensure education of children, be gainfully employed. And again, from a policy planning perspective, it tells us that mental health services should be aligned with settlement services, with employment services, right? So how do ministries talk to each other to create programs and not create funding silos? With regards to help seeking, so when there is a mental health issue, how does this Tamil community seek help, and how do they, how do they determine where they seek help, right? So one of the things that came up pretty significantly again was there was, especially with, with the immigrants who probably had difficulties in the language or who were not here for a long periods of time, the one of us in engagement is a huge factor. So Tamil speaking service providers or service providers from a like culture, the community tended to gravitate towards services provided by these service providers. Family physicians and service providers are key players in initiating care in terms of mental health care. There is an expectation of informality in engagement because a lot of times social issues, mental health supports in our home countries are not given by the formal system sometimes, right? And so there is this tendency to expect an informality in the engagement. And I'll just give you a small example. And the treatment expectations are very clear. It is a relief from symptoms and a renewed ability to function socially, right? In a manner that is meaningful to the community. So that was really the crux of what I found in terms of help seeking and engagement in mental health care. And I'll just read you a quote in terms of why language is important. So I've translated it, but it's verbatim, but translated into English. Going to a Tamil counselor was very good. It was great because however much we speak in English, especially with the limited knowledge of English, when we say pain, there are many types of pain, right? There will be pain that pricks you like needles. There could be pain like pressure. But when we say it in English, we can only say it is paining. So it's almost as if when you then just think about mental health, right? If you're talking about depression and if you're not able to communicate what you're feeling, it is going to be a challenge. And then there was another very interesting quote from a service provider. I'm just kind of mindful of the time. Can I take another 5 minutes? Would that be okay?
That should be okay. Go ahead, please.
Okay, I'll try and be quick. So, there was this service provider who was talking about who worked in the domestic violence field. And she told me that, sometimes women, call her and say, Akka, as we know, Akka is elder sister, can you talk to my husband? Can you help us get together again? Can you scare him a bit, right? So that he doesn't do this again. And because, and usually back home, this was a service provider telling me, they solve these things by involving other people, elderly people, respectable people. And so they feel that something can be done like this here. So even in terms of service provision and how we engage, right? In terms of mainstream, it is very, very clear cut in terms of boundaries, right? There is a rigidity. I'm not saying that we should call the husband and scare him. That is not what I am saying. But I'm saying that we have to think differently when we work with our communities. And what does engagement and an informality in engagement mean? And can we kind of design it within the professional boundaries in a way that's acceptable? Those are challenges that are posed to us. And just in terms of, how the community has been able to access help, we've seen more direct pathways to care for women in comparison to men, especially with mental health. Men are usually forced into the system, usually through the legal route or through a requirement of some kind of assessment. A number of younger single males are more prone to disengage from the system, right? This has been found through research. And probably this is one of the reasons that we are seeing our younger men, at a higher risk for a lot of things. And addictions in the Tamil community has been an ongoing issue, addictions to alcohol. And again, we see very few, culturally competent, anti-racist frameworks for dealing with addictions in the Tamil community. Then the other biggest, factor is cultural knowledge and understanding in intervention. Again, I'll just finish by reading you a small quote in terms of how one service provider educated the community about health and mental health. So the way I educate them is through one of the ancient Tamil poems, which is 2,400 years old, Purananuru, which is an epic in Tamil, and which was written by Kaniyan Pungundranar. So it's a story like a poet in the king's court. He was looking very healthy, not even a gray hair in his head, and others were amazed about his good health and asking for the reason. He said, I have a good wife. I'm blessed with good kids. I have good workers working for me. They do the work the way I want it. My king is my God. He's protecting us and not harassing us. And above all, I have in my village well-educated, experienced people with humility living around me. So the WHO definition of health was there in, in Purananoru 2,400 years ago. And we don't go to that, right? It's almost like we have to take pride and tell service providers and the mainstream here, we have a lot to offer you, hear from us, right? And which is why, I'm not going to specifically go into policy and practice because I think I've spoken about it. I think funding from ministry should not be siloed. That is a key factor. Health promotion and prevention need to move beyond the traditional realms of health. There should be collaboration with and capacity building in multiple sectors. The one piece of research, the one gap in research, I would say is really we have not done much research with second generation of immigrants, and also with other subpopulations within the Tamil community, like the LGBT population, right? So these are all gaps that we should be thinking of as a community as we move forward. If again, to Parvati's question, the question of this thing, are we served? We are served partially, but not the way we should be holistically. Thanks very much.
Thank you, Nalini. And we will hold on to the questions to Nalini. I think at the end of the sessions, all the 4 speakers would be speaking first, and then you also can, write down your comments or any questions in the chat box. You can leave it for individual speakers or commonly for all speakers. So thanks again, Nalini. That's a great talk about immigrants. So how people can think about from the Eurocentric box to the world-centric, and then the other cultural-centric or cultural perspectives, in serving, health services for immigrants, including Tamil population. So I'm really glad that you brought the word Akka. I was living in San Francisco. There was a woman who was, fleeing as a refugee, and she was detained in the San Francisco detention. And then she was brought one day to I was really so upset seeing her. She was only fleeing. She was handcuffed, hand to hand, hand to hip, hip to leg, leg to leg. So you can imagine how she could have moved. And she was placed with the women who were, lesbians in one room, and she didn't even understand. And the jail guards were coming and looking at her, and she was, and then later they, it is not about the lesbian thing, I'm sorry. So this is, my memories. These 2 Tamil girls, including her, they were put in one cell. And then one was sleeping up and the other one was down. So during the daytime, they come and stay together in the bed. And then the jail guards were coming and looking at them. Oh, this is something going on. So they separated them. So they couldn't. And then this one girl, I helped her to get out of this prison. And she said, Auntie, I never knew this girl. But in San Francisco Chronicle, they wrote, some auntie was there, and then she was lying that she didn't have any relatives in California, but this auntie was there. But the auntie, the term she said auntie, it's me. She didn't even know me. It's a common term people use for, calling older people, older than them. That is auntie, just like akka, like elder sister, the auntie. Anybody they call auntie or akka. So that's, these are the things that, some service providers do not understand, especially the mainstream population. They are not used to this, right? So thank you. It's a very, very good presentation. We also have issues with LGBT communities in our community. We are talking about LGBT issues, but we never talk about it in our community. There's no forum for it, or people are really struggling talking about it. Even some of the loved ones, you know, the son, even only son, he committed suicide because he couldn't open up with the family, you know. So this kind of thing is there. We do not have the forum. We do not have the funding offered to, you know, educate our community. There are a lot of issues that has to be educated. Thank you, Nalini, for bringing all these issues. Our next speaker is Professor Chandrakandan. He is known to our community and also many mainstream communities and services. He's been very, very well known. He was the first president of Basandam, the Tamil Wellness Center, when we built that, and he was serving Basandam for a long time. And he's still a well-wisher. Dr. Joseph Chandrakandan is going to talk about alcoholic and substance addictions among Tamil youth in Canada, familial, cultural, and ethical perspectives. Dr. Joseph Chandrakandan was a senior bioethicist at St. Michael's Hospital for over 20 years and is now a regular professor at the Faculty of Theology in the University of Toronto. He taught ethics and theology at Concordia University in Montreal, 1996 to 1999. His specialized area include mental health ethics, palliative and end-of-life care ethics, especially Hindu, Saivite, and ethics and Hindu, Saivite, Tamil ethics, and Islamic ethics. He has presented papers at several national and international conferences on religion and ethics, and has given invited public lectures at several European and American universities, including University of Oxford, Uppsala University in Sweden, and the State University of New York. He was also a professor in Jaffna University when I was teaching there. So we welcome Dr. Joseph Chandrakandan.
Thank you, Parvati, and thank you, Nalini, for this very extensive and clear presentation about issues that are facing the Tamil community. Now, I will be talking about three major issues, namely alcoholic and substance abuse, the issue of addiction among the youth in Canada, and looking at it from the perspective of family, culture, and also finally about ethics. We should realize the fact that we are dealing with a very serious issue here when it comes to alcoholic addiction or with substance abuse, issues that involve suicides, homicides, and sometimes overdose, death caused by overdose and so on. And therefore it's serious, it's important, it's also very critical. As Nalini said, as new immigrants, when the Tamil community came into Canada, in the early stages, the research was done, I think, between 2002 to 2005 or so, when Dr. Nalini was involved as coordinator of the research. And one of the simple issues that came out was that mental health issues among the Tamil community is not too different from the larger community. Namely, at that time already, in the early part of the century, around 2005 or so, it was common statistical data that 20% of the larger Canadian community has mental health issues. That does not mean that 20% have schizophrenia or bipolar or some other serious mental illness, but they need to address this issue. That mental health issue is a factor that has to be addressed, 1 in every 5 Canadian. And that was applied also to that. Actually, when the research ultimately was published, I think the title was Community in Distress, Tamil Mental Health Among the New Immigrant Tamil Community. That was the final document title when it was published. Now, from that time onward, what had been going on is our community had a sense of communality, which was very artificially put together until the year 2009, when the war was over. Namely, everyone's focus was on the country that they have left behind, at the home they have left behind, the relatives they have left behind, and therefore the focus was on Sri Lanka, especially in Jaffna, Bariklo, Manar, and other places from where larger Tamil community has been extracted. And therefore, the sense of communality or community was formed by the negative factor of the war. The achievements of battles and all that had been going on there were in banner headlines in the Tamil newspapers and publications, and in any Tamil news that you go into, whether it was on the internet or otherwise, it was all about the war. And if it's a battle was a successful one, then there was a lot of celebrations and so on. Therefore, the community did not have the time for deeper introspection, despite the fact research had been done and it had clearly pointed out that this issue had to be addressed. Secondly, from 2009 to 2010, 11, 12, there was a larger sense of confusion, sense of distress, sense of disappointment after the war, a deeper sense of defeat and confusion, and therefore, even that was not something that gave way for deeper reflection about our family, about our settlement here, about our life here, about our future, and so on. I think the ripples of that is what is being felt today, our failure to address ourselves in a coherent way. So what had happened in this process is our community started to dissipate, whether it is in terms of our temple worship, whether it's in terms of our togetherness, whether it's in terms of our planning as a community about the future. Of course, as Parvati said, there were few who were able to economically make successful life, and therefore they were separating themselves. A kind of elitistic community formation was taking place. And there was a large number that was left with daily wage, depending on, they had to go to work in order to support their families, pay the rent, and so on. And if you look at the larger number of mental health issues or addiction issues, or even domestic violence, as Nalini referred, in fact come from that community which is still struggling to settle down in this country. They are like stateless people, but they have the citizenship. So on the one side, we have a long distance nationalism that was keeping the community, taking the whole control of the community's attention. And once that has dissipated and collapsed, the community is now facing itself and is struggling to find its own niche or own place in a strange land. So this is a bit too late, I would say. Now coming to, therefore, the issues of alcoholic addiction and substance abuse, families go through enormous amount of struggle. We know how this affects families in the sense of family relationships, within the family itself, there is a lack of communication. Within the family itself, there is a sense of distanciation, and how children suffer. There are a number of children who have been taken away from families against their will, because Canada has its own norms and principles about child advocacy, and therefore in a family, if there is constant aggression or abuse, physical abuse of the mother by the father, or if there is serious forms of violence, then they take away the children. And the children are put up in a completely strange environment, which traumatizes the children. Actually, when I read about, for instance, how the early settlers took away the native children into residential schools and destroyed their lives. Whereas, because at that time, that was a norm. They said these children, if they are left with their own parents and brothers and sisters, they will be killed or they will die. Therefore, they said we are saving them, which was really not true. But the trauma and the subsequent other abuses that these children suffered is being now coming to the open. All these things happened in the last century, only in the 1960s, only 50, 60 years ago. And I don't think in Canada, no other community had gone through that kind of trauma as the Native Canadians. And even today, they are still struggling about mental health issues, about suicide, about addiction, and larger, if you take even on a population ratio, there is larger amount of addiction and substance abuse among them than others, even though the entire community is only 4% of the total population. And therefore, Tamil community has much to learn from them as well. I mean, even though this is a very serious issue, it's a critical issue, but at the same time, we should not get disappointed. There are communities that have been grappling with these issues for the last 40 years or so, or the last 60 years or so. My insights on this issue are, in fact, from my sitting at different ethics, as an ethicist, sitting at committee meetings in when we had patient reviews, or directly in family meetings. And even though I worked, my work was centered at St. Michael's Hospital. Actually, I worked from Hamilton to Bowmanville, covering more than 7-8 hospitals in between. And in most of them, there have been always 1 or 2 or more Tamil admissions. And I have had the opportunity also to sit with them and to listen to family meetings and so on. So without any strain of revealing any confidentiality, I'm just taking broad strokes from that experience to see that we address these issues and address them in a very sincere and serious way. And the question that has been raised as the topic of this meeting, or this little dialogue we have, are we served, is a very serious and important issue. Whether we are served effectively, whether we are served in the most relevant way, whether we are served as a community involving our families, as Nalini said, the ultimate cell of our existence is the family, because we are largely rural communities, and interlocking of families and the interconnection of families is the ultimate support. Drug addiction and alcoholic addiction, in fact, distances even from the family. The families go through enormous amount of pain, agony, anxiety when they find when the son or daughter is not coming home on time, when the son or daughter is exhibiting a different form of behavior. Even their whole physical outlook has changed. Therefore, familial struggle is one that has to be addressed, and that has to be addressed in a very systematic way. And we need to follow, there are enormous amount of research carried out and done. If you just go through what CAMH has been publishing, from their student days right through to families, there have been enormous amount of research done about mental health issues caused by alcoholic addiction and also by drug addiction, which these are the 2 things we are focusing on. When children begin to exhibit that kind of behavior, when the son or daughter does not go to the university anymore, or does not go to the college anymore, or does not have any attachment to the college or school, but even if he or she were to go to school, but their performance is very poor in the school, when parents begin to notice it, they know that something is wrong with the child. But then, as Nalini said, on the one side, even though there is a fading away of the stigma, but I think this brings about a completely different form of a stigma. When you find your son or daughter, the spouse is taking drugs, in the Tamil context, as young students nowadays, we only know that, if somebody is taking the common drug that time was known as ganja. If you take ganja, they would say that person is, they would be sort of ostracized from the community. They will be dealt with, even the whole family relations and others would move away from such people, because that will be a criminal offense. Whereas here, we know drug addiction and drug use and abuse is from the elitist communities right through to the poorest communities. It is not something that is confined to persons who are cast away from society. Whereas in the 50, 60 years ago, in our cultural context, it would be a person who is just cast away, pushed away as far as the person is addicted to liquor or addicted to, especially to drugs. Secondly, the issue that we need to address, so the addressing the family and focusing on the family is very essential, and that will not be possible without services that are organized, systematic, that have a plan, that bring out access possibility that will not in any way jeopardize their social respectability, because there are still many of us, as Parvati said, who are not willing to openly talk about issues about a son or daughter. When they are doing well in the school, we always make a big propaganda about it, and we have to be proud about it. But when a child who is also capable of many things, intelligent, a person who has number of other capacities, when that son or daughter begins to behave in a different way, the family hides it up or seeks advice from the wrong people, taking the person to the temple, having a blessing there, that's not going to solve it. Or even taking to a counselor who is a friend is not the right way ethically. They somehow, the typical Tamil way of doing it is to have, get hold of an influential person and then get hold of somebody. And all this is done in order to maintain secrecy. But that in the longer run brings about larger problems to the person who is involved in it. And therefore, on the one side, labeling and stigmatizing is as dangerous. On the other side, making it a secret and not permitting or allowing the person, but letting the person on a longer rope to go completely astray is not the right way of looking at it also. Secondly, I wanted also to speak about the cultural aspect of it, namely, how do we look at our own culture? Is culture something that is absolutely unchangeable? I don't think so. Should we always refer back to our own tradition and say, we are a tradition-bound society, we are a society with so much of traditional values and so on, we have to preserve it? I think there has to be openness there also. Culture is a man-made reality, or it's a human product. It's made by men and women, it's made by families, it's made by individuals, it's made by value systems, but it's open to change. There's nothing that is culturally moribund, is static and concretized. Therefore, our Tamil culture has gone through enormous changes in the last 20, 30 years after the war, not only by virtue of our migration, but even in our homeland, if one were to observe very clearly. But I've seen some of the research being done is, it's not very appropriate. I've come across anthropological and sociological research being carried out in Jaffna, even finding fault about Somasundaram and so on. Recently, I was reading an article by one writer about Tamil subcultures, and he says Somasundaram has not understood the social life and so on, which is, for me, it is unacceptable, because Dr. Somasundaram is one of the extraordinary psychiatrists we have in Jaffna, and I have worked with him in Shanti and so on. So, looking at Tamil community as a research as a research subject is as bad as looking at the community as an extraordinary kind of human reality. We need to look at tradition, yes, but we need to support and help people also to overcome barriers that are placed before us by what we call our moribund or our unchangeable culture. Culture is always open to change. And that change can take place in a very effective and also very dynamic way. And the change can take place in a productive way as well. The cultural aspects require greater attention because we often try to escape by bringing culture into the picture of treatments. Certainly, we need to understand the person in order to treat the person. Therefore, the historical background is very essential. The collective trauma that they went through is very essential, even though we did not, as I said in the beginning, we did not have the time to focus on the trauma. as soon as people arrive here, first they had to find a job, they had to find a place to stay. They had to for the first few weeks, they had to depend on the mercy of their relatives or some friends or others. So once they get an apartment and once they start working, then they have to support or pay up their loans. Many of them had spent enormous amount of money to come here, and therefore some of them have to pay those loans. Others will have to support their families. And then, of course, the war was on, and therefore there was the larger attention was drawn into that. And there was very little time for families. And if you look at the children who are now behaving in a way that we would want them to do, is partly because of that kind of negligence also. Many of our children who were brought in here from the age of 5, 7, 10, 11, 15, they were neglected. They went through very serious forms of negligence from the part of the families, because it's understandable on the one side because of economic hardships, because of the desire to have a house and car and so on, as symbols of settlement, as Dr. Nalini said. So sometimes those factors also moved us away from it, and therefore the cultural kind of picture that we created for ourselves, on the one side, we hid ourselves within this larger, on a national level, multiculturalism became a very fanciful label. I have serious reservations about multiculturalism, actually, even as a priest who serves in a church. In our church, there are so many different communities come to worship, and we see our church is very multicultural, but actually they come as segmented communities, they go back as segmented communities. They come for a common worship, that's all. There is no deeper interaction. There is no sense of community. Now, do the Tamil youth automatically will get the ability to participate in larger groups? When we were students from the age of 6 to university times, it was a homogeneous community, even though some of them might have been Sinhalese, others were Tamils or Muslims, but there was a general sense of community in terms of our race, in terms of our color, in terms of our external environmental conditions, in terms of our physical outlooks and so on. Whereas here, we are sending the students amidst people, languages, ethnicities, cultures, habits they have never come across. So on the one side, there is so much emphasis on our Tamil identity. On the other side, these children are facing day after day in their schools and colleges, and therefore their peer pressures begin to melt down. And then ultimately, there's been enormous amount of research done by Cambridge, and in a recent publication, Cambridge said South Asians who are addicted to, South Asian students in high school with addiction issues, either alcohol or substance abuse, is not very different from white students, from black students, from other racial, multi-racial communities and so on. They said it just ought now maybe a percentage or a half a percentage different. In other words, the peer pressure is so much that the fact that 58% of high school students have either consumed alcohol once or more or have been forced into do it applies to all. The Tamils are not an exception. In terms of our culture also, it's important to ask whether as Tamils we have the ability to participate in larger cultural groups with that same sense of openness, with that same sense of goodwill, or do our culture becomes something that with our desire for self-preservation, we try to bridge it up together, or we try to insulate it in a way that we wouldn't open ourselves to it. And thirdly, the ethical evaluation that raises a number of other issues and questions. The first issue is in terms of treatment. Can we look up to a service as Tamil community from non-Tamil medical teams and so on without any reservation that our specific psychosocial reality is taken into consideration in the treatment, which is important because of the collective trauma with which we come, the background which we bring together, and without understanding that, is it possible to understand and treat a Tamil youth or a Tamil family, whether there is serious domestic violence involved, or where there is serious addiction issues involved, where there is serious alcoholic issues involved. Culture certainly has a place there. And when I say culture, it is the psychosocial history that underlies that culture, which has to be in some way addressed. Secondly, the policies that are in place and the norms of treatment that are in place from an ethical perspective. As you know, most of our ethical principles are drawn from a Judeo-Christian background, and therefore they have a Western coloring. Whereas the larger sense of Tamil community and ethics does not give the priority always to the autonomy of the individual, which I have said many times in many of our ethics meetings with patients when it came to treatment. If you look at treatment, most of the ethnic communities, when their son or daughter or husband or wife is admitted to the mental health institute, most of the time it's a police admission. When they find the person is behaving in such a way that they cannot control it anymore, they cannot hide it anymore, that's the time they call the police. And most of these admissions are police admission, and therefore involuntary admissions. And once they are admitted, very often we go, the hospital norm is that you focus on the individual, and the autonomy of the individual is to be respected, and therefore the parents and others cannot come into the picture. And once that happens, all the decisions are taken based on what this person, whether he is capable or not, is willing to give his or her information. In other words, the primary ethical principle is focusing on the autonomy, the self-determination of the individual. But I always advocate that autonomy has to be a segmented autonomy, because in everything else, Tamil families, especially with younger, even if the son is 25 or 27 or 28, they form part of they don't treat that individual as holistically a different person. On the contrary, he or she becomes always a part of the family until they get married and perhaps leave the place. And therefore, to respecting that autonomy is ethical expectation from hospitals and admission centers and psychiatric institutions and treatment places and so on. Whereas on the other, taking the parents, siblings and others out, because these are the people who have been also going through the suffering. Just imagine if in a family of 4 children, the youngest one is 7 years or 8 years old, and the oldest one is 15 or 19 years old, and the oldest one is having serious issues of drug addiction, certainly it's going to have its impact on the 7-year-old. And therefore, involving the family in treatment decisions becomes very essential. And finally, in terms of our response to the question that is, are we served? I think we need to be served, as Nalini said, in the context of who we are in order to understand us. And therefore, we have here one of our MPPs, Taniha Salam, I saw his name in it. I hope he's following it as well, this webinar. We need to address this to the state, to the government of Ontario that has the duty to look after the health of all people. Of course, they are doing a great job, but at the same time, it's important that they focus. When research is done, you always see the research is done in a segmented way. Take most of the addiction research supported by the government of Ontario, or even when I checked through the Health Ontario's website, and also CAMH, most, if not all, the addiction research in the last 10 years have been segmented in the sense they have been studying different communities together. But then when it comes to responding to them, we always have a holistic one frame of reference. But I feel it's time that we begin to focus on individual priorities or collective priorities of communities. And in that, I feel the Tamil community is not served in the way that it should have been having lived here for the past 20 years and more, for me and for the others who have been here for more than 30 years, I do not think the Tamil community has received the kind of support and service possibilities as it should receive. Thank you.
Thank you, Dr. Chandrakandan. That was a very informative speech. I hope Mr. Thanikasalam, our member of parliament, is listening, and he's going to take some action towards this to make the Ontario government to understand the services that we need to, or have differently for each and every community, especially the Tamil communities that we are talking about right now. And Dr. Chandrakandan has brought a lot of very important, points about children, how they are affected, how mental health system is not really seeing the family as a holistic unit, and they are seeing them as an individual, just focusing on the patient alone, and that's not working with the Tamil community. We have seen that. It is sad to say in this context that there are other communities who are equipped with Hong Fook Mental Health Center has 3 different units now. They were in downtown, now they are in Scarborough and Markham. It's great that they are growing, but on the other hand, we as Tamil community, when you look at the hospitals and where the mental health services are not really great, because only 1 psychiatrist in some hospital and there are no counselors. Counselors are given, they are loaded with people with trauma and a lot of issues. So we don't have enough counselors. We don't have enough services for the Tamil community in our hospitals, which we have seen. Most of the people who are living in Scarborough and Markham area, we only have partial psychiatrists. They are working only like part-time. So some work in one hospital and some work in another hospital, like only 2 or 3, and we don't have enough people, enough psychiatrists to work with other areas especially with children or adolescents and things like that, right? So we are really longing for services for Tamil community, whether it's a wellness center for Tamil community, why it is not established yet. So that is a question that we ask from the community as well as from the governments, or all 3 levels of governments. We are longing for it. We were lobbying, but we are still not getting it. I hope they will listen to our cries. So we will go to the next speaker. The next speaker is Dr. Pushpa Kanagaratnam. She is a psychologist, a clinical psychologist. She's going to talk about on parenting while resettling, omnipresence of the past while parenting in the present. Dr. Pushpa Kanagaratnam, a psychologist, is a registered clinical psychologist in the province of Ontario and a member of the College of Psychologists of Ontario and the Ontario Psychological Association. She completed her professional degree and PhD in psychology at the University of Bergen and had practiced as a psychologist in Norway since 1996. She has experience working with different ethnic groups nationally and internationally, and has published peer-reviewed articles and done numerous presentations on topics of mental health, war trauma, post-traumatic stress disorder, and intimate partner violence in immigrants and refugees. Dr. Kanagaratnam is one of the national recipients of 150 difference makers and leading Canadians of mental health, awarded by CAMH. Thank you and welcome, Dr. Pushpa Kanagaratnam.
Thank you very much, Dr. Parvati, and thank you for the invitation today, and also for the presentations from Dr. Chandrakantan and Dr. Nalini Panlankar. Very interesting and informative. So, as we planned on this day today, I think Dr. Parvati had mentioned that it's going to be mostly mainstream for the mainstream, but it seems like we have a lot of people here from our own community. So there's kind of going to be some overlap, but I'm going to try and cut down on certain things that already the previous presenters have spoken about. So my presentation today is mostly, I think I'm taking it from a clinical perspective, based on what I'm seeing in my practice and what I'm learning from the research that we have been doing. So today, so we are talking about a war-torn country. Definitely we can say, the war ended many years ago, but we still talk about Holocaust. And we know that there is, true that we don't have solid research studies to have an evidence-based science behind the trauma that people like us in the Tamil community are facing, and many other refugee communities that are living in Canada. So either, as the other presenters have touched upon, funding issues, or we don't have enough culturally informed and engaged academics and clinicians who are in a position to influence the field. So when we are talking about, I think Dr. Parvati was part of my research when I did it in 2003, like 17 years ago. And when I immigrated to Canada, and we had this, I remember having this discussion with mental health professionals in the community, that this trauma is not addressed by anybody. The suffering Tamil people are going through is not being addressed. So how is this going to affect us as a community in the long term? How is it going to come back and haunt us? And today it is happening. So that is the sad thing. I'm seeing people in their 50s, 60s, 70s who apparently had no issues until like they suddenly had to kind of had an accident or something happened in their life, and they are just homebound, and they start to think about all the experiences they have gone through when they were 10 years old, 15 years old, how they were abused by the military, or what happened, how the family members were shot in front of them. So the thing is, we are dealing with people, like when you're saying parents, who are these parents? So they came in their early 20s, 30s, 40s, in their prime age. And all of the issues that they have experienced, the other presenters have already talked about. So, but in addition to all the disruption, all the trauma, all the experiences they have gone through, many came with already people who were already suffering from mental illnesses came, and people with learning disabilities, never diagnosed. They had to come and go through the same thing. So and mainly people losing hope and trust in other people, in governments, in relationships. Because when we talk about trauma, we are talking about, from a Western perspective, events that could create post-traumatic symptoms. But then, as Nalini was mentioning too, the social dimension of health is really something that the system is not capturing. And this was done. There was one research study, actually. I think Nalini's research, one of it was explaining the social aspect of mental illness, and I had a study done on war trauma, which also reflects the same thing. And there was another study done by Affleck and Thamodaram Pillai and some other co-authors on Tamil men, and how the guilt they were feeling about not being able to save their families through the war, and how they felt less less manly, and that was more traumatic for them than how they experienced, if they experienced torture or but violence or killings or whatever, right? So people come with all these baggages and they come to this country, and as I already mentioned, most of them didn't have a warm welcome. They had to come through illegal means. They had to fight for a status. Family reunifications were delayed. And I'm sure there are still families that are separated due to the immigration issues. Threat of deportations and having to pay the debts that they had to pay for the agents. And marriages became more based on obligations, a means of leaving the country. And for many young people, sometimes marriage was the only option, because even they didn't want to get married, but because it gave them protection, safety. So majority of them, they come here, they have no time to study the language, no time to work on their credentials, obligations back home, so they get married and they are in the age of giving birth to children, taking care of them, managing a household totally in a new country, and then buying homes that they could not afford to buy, because as a Tamil community, we know that we are very land oriented, and we feel home as a safety net for us. So we have to get a home. We have to buy something. And then after we buy the house, we start to figure out how to pay for it. So you get into 2-3 jobs. So now the dream is, how can you get everything out from your children that you haven't been able to? So how can you make your dreams come through your children? But you don't have the time to spend with the children. You take them to all sorts of classes, and I've had clients who are on social assistance, struggling for money, but they'll take their children to classes, and the child may be just 4 years old, but the child is getting getting tutored. So if you ask a parent, is your husband a good parent? She'll say, yeah, he's good, because he feeds the kids, he takes them for extra classes, right? Because love and affection is expressed differently, and that is what the first generation has been used to. So our culture it's not a non-verbal culture. It's a high context culture. So you show your affection towards the children by getting them the basics, being active with them, doing things for them. So a father who is working all the time is seen as sacrificing for his family, because he loves the children and he wants to provide for them. So how are the children viewed in our community? They are innocent, they need protection. We always take our kids to all sort of movies, right? Because we think, and we cry, like a mom comes to me, she'll cry, and her baby will be there, and the baby will be looking at her, worried. And I will say, no, maybe we shouldn't talk now with the child here. No, that's fine. She's fine. She will not know anything. She's a small kid. So we think that the children are not affected emotionally. So they have to be taught, So all this works back home because we are adapted to that system at home. Like any and every culture has its values, has its norms based on what is adaptable in that given situation, right? So it works in Sri Lanka, but here people are uprooted and coming to a totally different environment here, totally different norms and values and expectations. So it's going to be difficult. So here the children, in a way, they have a power. I'm saying power because for many children, I think that becomes the only safety net for them. So this is not something that a mainstream family of parents who are belonging to Canada, who live here, brought up here, they know what's expected of them, they know themselves, they know their kids, they know the system and everything. So the challenges that Tamil communities or any other community as a Tamil community is facing is different. I remember one client told me she was injured in an accident and she was feeling really bad that she was not taking her child out during the summer. So because they haven't gone on a vacation, and she was telling me that her child told, you know, you really need to take me out for something, because when school starts, the teacher will be giving us an assignment and they'll ask, okay, write about what you did during summer. So what am I going to write? So then my grades are going to go bad, right? So the mom really feels like, you know, for her being sick and not being able to take the child out is going to affect the child academically. So this is something that the child may know or may not know, and may manipulate the mom to get what she wants, right? Or maybe the child is innocent, she doesn't know. So the ability to take informed decisions and know that things are not, you know, rigid. It's difficult for a generation of Tamils who have not had the time, the means, the energy to learn to integrate or even understand the mainstream culture, right? So when it comes to a certain age, until a certain age, children are under the care of their parents. So they live with whatever is going on in the family. So we have parents who have gone through a lot, never addressed trauma, attachment issues, mistrust with each other, dealing with their own problems. There may be domestic violence, and having to keep the family intact in spite of abuse, and not having the time to be home because they're always working, and then they don't have the time to understand what's going on in the child's life. So they want the children to have everything. So in a way, you know, they want to get them everything, okay, but they're also very fearful of the system. So why a parent wouldn't physically discipline a child is not because the child will be hurt emotionally, but they just want the CAS to be not involved. They're afraid of the CAS, right? So because as Tamils, we view, our perspective is not legal. It's not about criminality or not criminality. It's about good and bad. So we just want a good outcome, and to get a good outcome, we'll do anything. And also we have this cultural aspect of causality. Like, we don't think in a linear way. We don't think, okay, this happened, so because of that, we are facing this. We have many different understandings about things. Maybe it's bad time, you know. So these cultural nuances need to be understood to be able to help our community. So many service providers have stereotypes, and they think that they are having culturally informed practice, which is not true. And also, a lot of confusions happen when expressing your distress, like suicidal ideations. So we know, like, I'm going to kill myself. What is it going to lead? You know, it's going to lead to a call to 911. But suicidal ideations can be a way of expressing, you know, your distress, and mostly a weak family member who wants to communicate something to a dominant family member. So it's an effective way of, you know, expressing yourself. But then these expressions of distress by a mother is often, you know, you see that one parent is saying, okay, I'm suicidal. And the other parent, who is very much integrated in the system, he knows or she knows how to manipulate that and get the other parent accused for mental illness, right? So at times, this fear the parents have, it is manipulated by the child too. So the child, they're not used to addressing the emotional issues the children are having in a way that is accepted and acceptable here. So many of them are first-time parents. They rely on what they know. So how were they brought up? And that's the way they're going to bring up the child here, right? And how is the communication with the school and the family? Language is the barrier, and schools and communication with schools, understanding learning disabilities, it's all very limited, because we you know, I know even many of my relatives, not many of my relatives, like few relatives I know who, you know, who would have so many somatic complaints when, and they'll be taken to that hospital, this hospital. And then later on, we learned that they have had a learning disability, because these things were not identified or diagnosed back home. So here, the understanding of that becomes difficult. And parents are embarrassed to communicate with the school, and many times children are embarrassed to bring the parents to school, because We know a lot of children get bullied about their parents at school. So challenges that are unique to many of refugee communities. And then relying on interpreters. We sometimes think, oh, we can connect someone to the same community, then that's fine, they're well served. But no, like there are many difficult, like there are many challenges with many interpreters, and it's not the ideal situation. And interpreters have their biases too. So growing up into the teenagers, children are in this dilemma. So there is a clash between parenting norms, what they have been taught, and what's happening in the home. And they get embarrassed about their parents. They may feel that their parents are not understanding them. So for many parents, children are their first connection to the system. They see and understand the Canadian society through the eyes of the children. But children are sometimes forced to take sides because they love their parents and they may feel like they need to defend them, or they may feel the need to identify and align with the mainstream for protection and respect. So some of the examples Dr. Chandrakantan was mentioning as well. So interventions actually separate the children from their home and from their communities. And how is the system failing in all this? Are we served? That's the other way of putting it. So we have, in the mainstream, we have not been able to identify the hidden trauma in the community. Our tools and approaches do not fit with the community. And settlement has not been a systematically planned process for this community. And our intervention strategies for domestic violence or drug use, it's not working with a community that values community belongingness. So for Tamils, belongingness in the community is as equally important as individual well-being, or sometimes even more important. Community belongingness becomes more important. So what's going to happen if the only option you have is to call the police and alerting the whole neighborhood that something is wrong in this family, and going into a shelter, separating from a spouse, and consent and confidentiality issues, again, as the other presenter was talking about, it assumes that the parents are well informed, they have the power to control the child, and they are going to be interfering with the child's well-being. So, and it assumes the child is powerless. But maybe it's the first time when a child is into the mental health system, maybe it's the first time for the parent to get some help to understand what has gone wrong and correct it. But no, they're not allowed to share information about the child. And so service providers, biases, and the framework they're having, they're not educated in cultural norms. And even among our Tamil community, there are biases in service provision. But then there is this, without understanding the community, there is all these stereotypes that these cultures condone violence, right? Mostly all cultures, all human beings want good for their children. They don't want to harm the children, but parents are scared and insecure. So I would just like to finish off with just a quick recent clinical example. Just to confidentially, I'm not going to, I've changed some information here. So a child is into drugs, so not hard drugs, marijuana, and the mother is extremely worried about this. She wants a good future for her children because she herself struggled in school, possibly with learning difficulties and mental health issues. She was never diagnosed or treated. So she gets married to a man who is kind of protective, but he is abusive or he's violent. He has anger issues. So the child gets hit by a hard object by the father because the father wants the child to stop using drugs. But for the child, it was the only safety net he had. The older friends in school who did drugs. Because for him, home did not provide the warmth and security. At school, he was struggling academically and he was bullied. So his head was bleeding after the father struck him. And the mother was so scared to call for help because that may lead to her husband getting arrested. So she's not willing to lose that support from her husband and also losing the reputation in the community. So she's worried about how the children will be viewed by others in the community if they're separated. So for the child, it's almost like unbelievable. How can my mother not protect me and get me help when my head is bleeding, like it's blood all over. So the trust and betrayal trauma for the child. And the child had to call himself to the emergency and go to the hospital to get stitches. And then the mother calls the police in another incident. So this is a very recent example I'm giving you. So mom calls the police the other day and telling the police that the son hit her, because she said, so her explanation is she didn't know what to do to help him stop the drugs. So she called someone, and someone said, okay, call a lawyer and talk to the lawyer. And she called a lawyer, and the lawyer said, call the police. You know, you can't do anything. The child needs to learn a lesson. So she found out something and said, okay, my child hit me. And then wanting to protect the parents, so the child is taken into custody by Children's Aid, and wanting to protect his mom, he said to the Children's Aid, okay, maybe I hit her, I don't remember. So this Children's Aid is confused, like, is this child psychotic, dissociating, or why is that the child hit but he doesn't remember, right? So I'm just leaving this as a clinical example of how the situation is with regards to challenges in parenting, taking care of children, and the safety of younger members in the community. Thank you.
Thank you, Dr. Pushpa Kanakaratnam. That's very informative and interesting aspects of families that they are going through, what they are going through in Canada. You know, after bringing the baggages from home, and they still have not opened the baggages. Still, they have some baggages unopened. You know, behind your I think on your wall, we could see the Palmyra tree. So the Palmyra is replanted here, but it won't grow in this snow. So we really have to adapt. And then the system also has to understand. The systemic racism is, you know, partly, you know, when you look at all the issues that you were talking about, why people, the service providers or Children's Aid Society are not understanding the families and the issues that immigrant families are facing, Tamil families are facing, because they are not, they are closed. They don't want to open. So if they are open, they will really want to learn about history, would want to learn about their issues, want to learn about the culture if they really wanted to serve. So who is prepared? Is it open? Is it given? Is it directed by any you know, policymakers of these organizations or government or anybody? So that is where the system fails. So we are seeing that as it is reflecting on our society, on the Canadian society, and it is really hurting our society because our society, the immigrant society, is not treated. We are not heard. We still cry for our, you know, look at the indigenous people, you know, they are the owners of, you know, First Nation people, but they still struggle. Why? Why they are not heard? How that woman, you know, yesterday about that demonstration a week ago, the woman, you know, was killed. You know, she's traumatized. So how much trauma, you know, this is the collective trauma. So how long they have been, you know, struggling. So we are struggling along with them. So all these people who are struggling, we have to come together and fight against this atrocities that they are made towards our communities. And we have to make them to understand. We have to make our own baggages open and discuss about it. And we have to find a way to do this. It is also in our hands. We cannot just believe that this is going to happen overnight. So we really have to fight along with the other, you know, other tools or other communities who are really the Black Lives Matters. You know, they have come up, opened up, and they are fighting. And so we really have to join this communities that are really using these tools. So since the time is really, really, you know, taking up, so we really have to call our next speaker, who's our psychiatrist, Dr. Senduran Gunaratnam, who was also working with Vasantham as an addiction counselor. So we are really proud of it because he really worked with Vasantham and now he's a psychiatrist and trying to help the community. Dr. Senduran Gunaratnam is a staff psychiatrist at the Scarborough Health Network. Indeed, Dr. Gunaratnam is one of the very few psychiatrists who is fluent in Tamil language, with being mindful of cultural barriers in treating Canadian Tamils foreseeing mental health challenges. In addition, Dr. Gunaratnam practices as a physician lead with the Community Liaison Program at Durham Mental Health Services. With confidence, Dr. Gunaratnam also serves as a lead for the continuing medical education amongst the psychiatrists at Scarborough Health Network. Furthermore, Dr. Gunaratnam is a lecturer with the Department of Psychiatry at the University of Toronto, while also representing SHN for the Medical Education Committee. So Dr. Gunaratnam is going to talk about the barriers to access mental health from the physician's perspective.
Thank you, Dr. Kandasamy, for the opportunity. Thanks, everyone. Can you hear me well?
Yes.
Thank you. I think we have to wrap up in the next 15 minutes. So I would aim in the next 5-10 minutes to finish, so we will have some time for the questions. I think that's very important. I think it's a complete forum in a sense that we appreciate the way Dr. Pandalankat started from a research perspective and also the cultural perspective all the way from rooted in Sri Lanka. And Professor Chandrakantan talk about the issues that we are facing with the youth and young people, especially when it comes to addictions. I always admire when Dr. Kanagartnam speaks about the psychological aspect that's very well rooted within the community, that's contributing or like negatively impacting the treatment outcome. So I would like to talk about some more practicalities that I'm facing as a physician working. It's one of the hospitals in Scarborough. Of course, the Rooch area is the Tamil pocket where I work, and we have a MPP here at Sri Lankan Tamil, and we have a minister Sri Lankan Tamil. So, I really wanted to talk about are we well served in GTA. Not in a political perspective, more of a service provider perspective, so we can enhance as a team to contribute to this community, which is really in need. I will give you an example. So when I worked as a physician, I was trained at University of Western Ontario to become a psychiatrist. So when I was at Western, I had the opportunity to assess and treat patients, primarily mainstream population. Say, if I would have seen 100 patients in that area, I would say that out of 100 patients, that maybe 40% of them that I had to follow them on an ongoing basis. That itself says to me that another 50 to 60% of population that their illness is not as severe as that you would imagine to be followed by a psychiatrist on an ongoing basis. When I went to Thunder Bay for was part of my training for a while, I was so shocked by the complexity of mental illness that our First Nation population has been going through. That's very complex, very well underserved. And the treatment, it's very difficult. It's not, if I talk about pharmacotherapy, that these patients would have been on like 5 different medications and none of them working. And there's a psychologist working on the side. There will be a case manager working on the side. They will in and out of the hospital. Substance use, abuse, trauma, molestations, war, fighting, shooting, suicides. It's a very complex issue that I had seen it. Then I was shocked. Expected, but I was shocked when I see it directly. When I came back to Scarborough, I wanted to work in Scarborough. I wanted to become a psychiatrist. I didn't want to stop my training to become a family physician to work. No offense, but I think the psychiatrists kind of were in a huge need at the time when I was finishing my training. So when I came back to Scarborough and started working as a psychiatrist, that the Tamil population that I work with, I personally feel the same complexity that I have seen when I worked in Thunder Bay with First Nation population. I'm not exaggerating this. The war, the way it made the complexity of mental illness among Tamil patients that I see or that we represent in a way, the treatment become very difficult. They are very severe, they're struggling with severe and persistent mental illness for the most part. It's not mild depression, it's not mild anxiety that we are treating here at the hospital. They're very severe complex illness. They need, in terms of medication perspective, they may need an antidepressant and a mood stabilizer and an antipsychotic medication. We may have to put them on treatment-resistant regime like clozapine or electroconvulsive therapy. Dr. Kandasamy and myself, that we share a number of patients, and she knows what I'm talking about. Why this is so complex? Nobody knows, unless a speculation that other three speakers already have mentioned. Partially it's war, partially it's related to immigration, partially it's related to cultural maladaptation, if that's the right word that if I wanted to quote. And there are other barriers in terms of perceiving treatment. First of all, the access to the treatment is very difficult. For an example, if somebody is severely mentally ill, there are only few ways of accessing to healthcare. I'm talking about the extreme patient population, which I deal with on a daily basis. The primary way of handling somebody either violent or suicidal or acutely symptomatic, it's calling 911. How many of Sri Lankan Tamil Canadians call 911 on their loved ones? Very rare. Because we don't see police as a friend. My younger son, he's watching cartoons and stuff. And in the cartoons, one of the cartoons is called Caillou. And Caillou talk about police is a friend. So the mainstream population from the childhood, they learn cartoons, they watch stuff, and they know the cultural adaptation, how to utilize emergency response services for their own need, which is lacking very much in our community. We don't see police as a helper on an emergency situation. The police crews patrolling in my area, I feel somebody is doing some offense. Either somebody is stealing, somebody is doing some bad thing in the area. So we don't approach to the proper services. Second option is going to the Justice of Peace and getting a Form 2, which is also very underutilized. The reason is that we don't want to go to the court system because the court system is only to be utilized if somebody had done something criminally. So we don't really utilize these emergency response services very well. The other part of that, engaging in the treatment in an outpatient care. I used to make this as a joke, but I don't think it's just a joke. It's more of a fact. People usually come see me in my clinic as an outpatient clinic. They usually come that they don't belong to that environment. This is something that they should not be there. It's magical. Somehow they got in there. And they wanted to say how I look like and how I'm feeling. If there's a 1 hour consultation that you book to see a new individual in your clinic, you need to prep them at least 15 to 20 minutes to get the fact, even though you know from the family physician's referral what's going on, to engage that client into that in that environment to get the information and complete it and start treatment. You're going to spend half of your time. As a person who's fluent in Tamil, I can understand the basic colloquialism in Tamil. If this is a stomach pain that can be represented at 6 different Tamil words, I can just name at this point. If I can understand those fine details in Tamil, even though it's so difficult for me to complete a regular psychiatric consultation within a certain time, I'm just wondering about a mainstream treatment provider. How is he going to assess this patient within that timeline? Because time is money when that comes to healthcare. So every physician or every healthcare providers will have to stick with that template. It's very difficult to abstract the core information on an initial visit from a patient who comes for the consultation. I have seen patients following up from different clinicians. They were misdiagnosed, they were underdiagnosed, and they were mistreated because of the language barrier. You cannot expect an interpreter, which is amazing services. No often I salute what they're doing. An interpreter can interpret somebody's emotions when that comes to mental illness. We can interpret the words, language, but not the emotions. And the representation, the way from Freud's language is more of a historical way of our middle-aged woman presenting to a psychiatric clinic is misinterpreted as malingering, conversion disorder, or factitious disorder. But it's actually maybe a severe form of depression with psychotic features or somatic symptom disorder. The idea of having the right diagnosis in this patient population, it's very complex. So that's going to determine the treatment. We had a very reputable psychiatrist who passed away a few years ago. He carried a huge patient load. And when the psychiatrist passed away, that this patient had to be spread to the other physicians from mainstream, they belongs to the mainstream. Some of the patients, the medications were stopped because the patient looked normal. There's nothing wrong in the patient. Patient is not psychotic. He comes to the appointment. They stop the medications. And even after a few months, the patient had a severe relapse. Nobody did understand what was really going on in this situation. This physician assessed these patients for a long time, and he found out those fine-tuning psychotic symptoms, and he put them in medication and maintained them in those treatment, which fell apart because of cultural misinterpretation and understanding. So what I'm trying to say that I'm not putting anybody under the bus, but it is a very complex way of presenting when that comes to mental illness, including our primary care physicians. They are really struggling. I mean, I wish that half of the present viewers today should be filled with primary care physicians, because they're the one seeing these patients first time. They are the one dealing with the issue. If they don't understand or assess the issue, the severity of the issue at the very beginning, it's going to delay them getting the treatment. For an example, when it comes to schizophrenia, the duration of untreated illness, which is the goal, which is the key for recovery of schizophrenia or reducing the duration of the illness. If they don't really recognize schizophrenia early on, for an example, oh, my son is like staying at home playing video games, he's not talking to anybody, he's isolated, he may be talking, mumbling in the dark, sudden change. It is interpreted as a behavioral change. It is interpreted as social anxiety, but it actually is an initial form of schizophrenia in some individuals. If you don't recognize that part early on, you're going to delay the treatment. It is very common that I see in my population. As I had to publicize myself that I'm the only Tamil-speaking psychiatrist or like working full-time in Scarborough. Am I happy about it? I'm not. I would say if I can have another psychiatrist working with you who understands the culture, his schedule can be filled for the next 6 months tomorrow. We have a huge need. We need at least 4 Tamil psychiatrists in Scarborough. We need at least 10 cognitive behavioral therapists in Scarborough, 20 case managers in Scarborough, maybe 10 psychologists in Scarborough. Think about like this severe illness being treated by counselors. They're doing an amazing job. Psychotherapists, I hats off to them, but the complexity may not be adequately treated by certain modalities that a funding agency has to stick with their own schedule and give a piece of a pie to this community. Scarborough Health Network has a one CBT therapist among another 15 therapists. And this population is huge, maybe 20-30% of the population, but we only have a very limited number of clinicians. How are we going to handle this patient population? As I said, that the complexity of the illness is very severe, but we are giving them counseling. Counseling is pat on the shoulder. Counseling is not interpersonal therapy. Counseling is not trauma therapy. Counseling is not cognitive behavioral therapy. Who are the ones providing these therapies? Nobody. We have no clinicians or very few clinicians actively working for full time to treat these patients who have severe illness. Psychiatrists, we prescribe medications. We couldn't spend enough more frequent time with these patients to give them a complete treatment plan. When these patients hospitalized, there's a huge language barrier. Yes, you can have an interpreter one time to get the initial assessment, and this patient is going to be in the hospital for a month or two, and every time the clinician, is he hiring an interpreter to talk to this patient? No. So we are very underserved as clinicians, that we are not really doing the job. I'm going to end this. I have a lot to talk about this, but another time. I'm going to end this with a very personal note. I excelled in my education in Sri Lanka. I got 8 distinctions, including English literature. I got 3 A's. I came third in scholarship. I was the excellent student. When I come to Canada, I struggled to get into the system. I did not even understand what's going on the radio, what's going on CP24. I studied English. I got a distinction in English literature, but no, it's a different accent. It's a different way of speaking. It's a different culture. When I got my residency in psychiatry, all my friends, doctors, family members, they look at me that I'm doing some sin. I'm doing something wrong. Why are you choosing mental illness? You're an excellent student. You should be a surgeon. You should be some cardiothoracic surgeon. You should be some other specialist. Why are you choosing mental health? So the stigma on becoming a mental health clinician is still huge. So our young population, the students, they study psychology in undergrad. I have patients, they're proud of their children studying psychology and social work. After a few months, few years, when I ask them what they do, they switch to business. Because something happened in that dynamics. When they're doing undergrad, they study psychology, but when they move into their career, they don't follow that they don't see that there's a career path for them. Not all of them, not most of them, and that's why we don't have enough people they're serving in mental health. And also that there's other stuff that we're talking about, like these clinicians, we don't have enough people, and even we have enough clinicians, there are a lot of people that they don't necessarily think that we need to serve to this particular population. There are Tamil cultured doctors, or social workers, clinicians. They don't necessarily want to serve to the Tamil community. We don't know why. So those things need to be changed. And working in mental health is a blessing. And working as a mental health clinician, of course, financially, you'll be very well paid off. So there are lots of incentives, and that satisfaction, you make change in. I don't think I will ever be happy to treat somebody's pneumonia by giving them antibiotics and see them that they're okay tomorrow. I don't think it's myself, but I'm very happy that I'm making change in somebody's life as a psychiatrist. You're touching their hearts. Not everyone is going to come and tell their personal story to you. Not everyone is going to open their heart, or not everyone is going to come in your office and talk about that the abuse they've been going through, that the family dynamics, the children's mental health. You are a blessed person in a sense that you serve this patient population. They had gone through a lot. They're still struggling. So, I mean, my kind of humble request is, as a community, we have to encourage more people to serve for mental health. I guess partially, I think that if you don't have a proper education or knowledge in mental health, that's going to turn a stigma, and we are going to become defensive when it comes to mental health treatment or policy changes. So that goes from a school teacher all the way to the Ministry of Parliament. It varies to a wide range from different healthcare providers when they serve to this patient population. I'm going to stop now. Thank you.
Thank you very much. That's a very, very emotional and community informative talks, people who are really wanting to serve the community. So he has given the area of changes, and people who are really willing to help the community to reach these services, and they will be. So because when we considering the time, it is really, really difficult. So we will be opening up for the questions, and then the chat box, I think the questions are directed to speakers, and I think they can deal with that. But we will also ask